All right. So, our former chairman for many years ago in pathology, um, Paul Klemper, I found a forward of his that he wrote for the textbook of Anderson's Pathology back in 1961, and an excerpt of his forward basically reads: "The everyday word disease is an abstraction, and abstractions obviously cannot be the immediate object of natural science, which is necessarily founded upon observation of natural phenomena." So basically, as we gather more facts over time, the goalpost moves back and forth, and we're constantly lumping and splitting diseases accordingly as time goes by. So the diagnosis of cutaneous inflammatory disease is based upon close clinical pathologic correlation. And microscopically, what we look at is what type of inflammatory cell is present, what's its relationship with components of the skin, as well as what is the adaptive response of these components within the skin to the inflammatory insult. But what about the elements that we can't see under the microscope, so such as soluble mediators of inflammation? So it's like being in the back row of Lincoln Center and being able to see the orchestra, the string section, the brass section, the woodwinds, but not being able to perceive the music. But one other element we can do, in addition to being able to identify what instruments are there, is actually look around the room and see what kind of reaction or response the music has on the crowd. Okay. So the adaptive response is also important in identifying, what's happening immunologically in these patients. So inflammation is one of the first responses of the immune system to infection or toxic injury. It can be initiated by the innate immune system or the adaptive immune system. And these are the topics we'll be discussing today. Predominantly dermal infiltrates, viral xanthum. These patients present with a very nonspecific picture, a diffuse maculopapular rash with an occasional purpuric component. It's associated with systemic viremia, and histopathologically, the findings are also nonspecific. You have perivascular lymphocytic infiltrates, maybe some mild spongiosis, maybe some interface, and maybe some red cell extravasation. From a pathogenesis standpoint, this is basically associated with a strong innate immune response as well as an adaptive immune response. These patients, the viremia signifies a breach in barrier, and it's met by a full-blown systemic innate immune response. The viral infection, the viral particles are basically going to activate cytosolic nucleic acid sensors on epithelial cells, macrophages, endothelial cells, as well as plasmacytoid dendritic cells. So the innate immune system will be activated, and we'll have secretion of type 1 interferons, as well as IL-12, resulting in potent induction of Th1 cytokines, which will eventually result in the secretion of IL-2, which is going to activate cytotoxic T lymphocytes, which will eventually then cause destruction of the virally infected cell. So this is actually a slide from a talk I gave last year at the ASDP in Chicago, basically looking at a viral xanthum versus acute GVHD. And you can see basically here in the viral xanthum lesion, there's MXA expression, okay, within the epidermis as well as inflammatory cells and vessels. And MX proteins are synthesized in a dose-dependent manner from two genes for which type 1 interferons act as positive transcriptional regulators. And basically, in general, MXA expression is considered to be a nice surrogate marker for the type 1 interferon microenvironment. Morbilliform drug eruptions. The clinical picture is also nonspecific. It's a diffuse symmetric erythematous maculopapular eruption. Histopathologically, there's a perivascular infiltrative lymphocytes and scattered eosinophils. And again, epidermal patterns may be present or not present. But in terms of the mechanism of disease, it's actually very different than a viral xanthum. The role of the innate immune response is actually not well understood, but in terms of the adaptive immune response, drugs act as haptens, which will covalently bind to peptides, rendering them antigenic, at which point they'll be presented on MHC class II molecules on dendritic cells, macrophages, and lymphocytes, which will result in the activation of Th2 cells and the Th2 cytokines, such as IL-4, 13, and 5. These cytokines promote B cell production of IgE as well as IgG4, mast cell deactivation, macrophage deactivation, as well as mast cell and eosinophil responses. And it's actually these mast cell and eosinophil responses which are responsible for the main findings that you see. They basically amplify and sustain the inflammatory response without additional exposure to the triggering antigen. And that's why a lot of times you have to treat these patients with a course of steroids in addition to just withdrawing the medication. Urticaria is an extremely common group of disorders that shares a common clinical and histopathological features, but a very diverse etiology. Acute urticaria is defined as less than 6 weeks duration and frequently is associated with an allergen or infection. Whereas chronic urticaria is greater than 6 weeks and is typically idiopathic, but may be autoimmune or even physical urticaria, of which case the trigger is associated with, say, cold or pressure, UV exposure, or even vibration. Microscopically, acute urticaria typically reflects a type 1 hypersensitivity reaction, an activation of IgE antibodies cross-linked on mast cell surfaces. And so what you're going to see is a sparse perivascular lymphocytic infiltrate with interstitial neutrophils and occasionally some scattered eosinophils. Now, in regards to chronic urticaria, it has a much more complex pathogenesis for mast cell activation, which can include physical as well as complement, anti-IgE antibodies, or even direct histamine-releasing agents. Also, non-mast cell mechanisms have also been reported in your chronic forms of urticaria. And what's interesting is that the physical types of urticaria that are attributed to, say, vibration or cold temperature or pressure have a stronger association with what's called neutrophilic urticaria, in which there's more of a robust neutrophilic infiltrate with only few eosinophils. The significance of this is actually not well understood. This is actually a diagram taken from Dr. Yoritsu's book, just showing the myriad of different stimuli that can result in mast cell degranulation and the induction of the urticaria reaction pattern. Leukocytoclastic vasculitis is a type 3 hypersensitivity reaction against vessels. It's typically the small caliber vessels. You'll see fibrin thrombi, necrosis of vessel walls, as well as perivascular neutrophilic infiltrates with leukocytoclastic debris. So the mechanism is basically the antibody-antigen complexes circulate through the bloodstream, get deposited in vessel walls, which will activate then complement, which will act as a chemokine gradient, bringing neutrophils into the site. They'll bind the FC portion of the antibody, resulting in degranulation, and then cell-mediated destruction of the vessel wall, inducing thrombosis. Okay, typical antigens that can be associated include medications, microbes, food products, as well as self-antigens. Spongiosis. So spongiotic dermatitis is typically divided into exogenous and endogenous types. And Dr. Gutman discussed the endogenous types very well. In terms of exogenous types, it's typically divided into either irritant or allergic-based etiologies. And if you just give me this biopsy here with no clinical information whatsoever, I really can't tell you why this patient has spongiotic dermatitis. There's no etiology can be determined, unless there's correlation with the clinical findings as well as possibly ancillary tests such as patch testing. But there are some subtle features with irritant contact dermatitis. It's activated innate immunity due to direct injury of the skin without prior sensitization. You see there's edema within the epidermis and exocytosis of lymphocytes and neutrophils. There's absent Langerhans cells and eosinophils, and frequently you'll see hydropic or swollen change of the keratinocytes within the epidermis. And in terms of the mechanism, there's multiple factors at play here. The intrinsic factors such as the overall barrier integrity, but also extrinsic factors such as the nature of the irritant itself. What is the concentration of the irritant and how long is it applied to the skin? And what happens is basically once there's damage of the keratinocytes, DAMPs will be released, or damage-associated molecular patterns, which will activate toll-like receptors in activating the innate immune response and secretion of IL-1, TNF-alpha, and the augmentation of inflammation at the site of injury. If you look at photoirritant or phototoxic dermatitis, this is basically when an irritant absorbs UV light and lowers the threshold for UV light exposure needed for keratinocyte injury. You can see here within the epidermis, there's scattered necrotic keratinocytes throughout. And if you notice, there's no lymphocyte cytolytosis. Lymphocytes are not in direct apposition to the necrotic keratinocytes, and that basically implies that the necrosis is not due to an immune response. It's metabolic, okay? And what happens is these necrotic keratinocytes will release DAMPs, which will activate the innate immune response, as essentially with an identical picture to irritant contact dermatitis. Allergic contact dermatitis is dose-independent adaptive immune response against antigen due to prior sensitization. Characteristically, what you see in allergic contact dermatitis are going to be large spongiotic vesicles containing Langerhans cells. And again, this implies an antigenically driven process. You'll see some dermal eosinophils and plus and minus some neutrophils as well. In terms of the mechanism, it's a type 4 hypersensitivity reaction in which contactants act as haptens. They bind to self-proteins, rendering them antigenic, at which point they'll be processed and presented to Langerhans cells on MHC class II molecules. These Langerhans cells will then leave the skin and migrate to the lymph nodes, where they'll present the antigen to naive CD4 positive T cells, which will then become activated into effector T cells as well as memory T cells. Then on re-exposure, memory T cells will migrate to the skin of antigen localization, release cytokines and chemokines, and recruit other numerous inflammatory cells that are characteristic of eczema. Now, there's actually a great paper that was written, published last year by our own Drs. Dinger and Gutman, basically looking at these cytokines associated with allergic contact dermatitis. And there's been some controversy in the literature, is it a Th1 immune response or Th2? And it turns out actually it's both. And it all depends upon the allergen applied to the skin. And what they found was that basically nickel demonstrated the highest immune activation with potent induction of innate immunity with Th1 and Th17 cytokines, whereas fragrances and rubbers demonstrated a strong Th2 bias. And if you look at it, it actually kind of makes sense as to why sometimes with spongitic dermatitis, you may actually truly have allergic contact dermatitis that contains neutrophils. In other cases, it contains eosinophils. So this kind of dual cytokine nature of allergic contact dermatitis kind of explains the lack of specificity in terms of the cellular infiltrate present. Whenever you have a systemic photoallergic or eczematous drug eruption, you tend to have a superficial and deep inflammatory infiltrate, and this kind of makes sense. It kind of implies an inside-out process versus an outside-in, a topical process. And in reality, both conditions actually frequently overlap and incite one another. The progressive accumulation of edema results in cytolysis of keratinocytes. It's the shredding or the ripping apart of keratinocytes. And this actual direct keratinocyte damage will release DAMPs, augmenting the innate immune response. Additionally, alter barrier function will increase antigen penetration and the augmentation of an adaptive immune response as well. Now, the adaptive response of the epidermis is going to be hyperplasia, okay? So if you actually notice, the inflammation in spongitic dermatitis occurs within the middle layers, okay, of the epidermis, and therefore the basal layer, stem cell layer, is actually intact. What happens is you have a hyperplastic response with increased keratinocytes and transepidermal elimination of the irritant or the allergen, and additionally, usually the inflammation as well onto the surface. So vesicles going to crusting, going to lichenified plaques. The interface reaction pattern is typically divided into cell-rich, which is basically lichenoid, and cell-poor, which is cytotoxic or vacuolar interface dermatitis. And the prototype for lichenoid dermatitis is lichen planus. It's considered an idiopathic dermatitis associated with multiple environmental exposures, including viral infections such as hepatitis B and C, as well as medications, vaccines. And it's characterized by a superficial band-like lymphocytic infiltrate with destruction of the basement membrane and sawtooth formation, as well as dyskeratotic basilar keratinocytes, colloid bodies, and premature terminal differentiation of the epidermis. And classically, you're not going to see eosinophils in lichen planus. In terms of the pathogenesis, the etiology is unknown. It's widely believed to be an autoimmune delayed hypersensitivity reaction against an undetermined epidermal neoantigen. And the theory is that basically epitopes on lesional keratinocytes are modified by viral or drug antigens. And we know that early on, there's increased Langerhans cells within the epidermis that process modified epidermal antigens to T lymphocytes, probably through MHC class 1 and 2 molecules. And also what's interesting in lichen planus is that keratinocytes express MHC class 2 molecules, which is somewhat unusual and unique to, and is thought to play an important role in the pathogenesis of lichen planus, but is yet to be determined the precise role. So although CD4 positive T cells dominate the infiltrate, keratinocyte destruction is mediated by CD8 positive cytotoxic T cells. And it results from the activation of cell death is due to the activation effects of interferon gamma, IL-6, and TNF alpha. And once TNF alpha stimulated keratinocytes will express increased concentrations of fast receptor on the surface, at which point cytotoxic T cells will bring in fast ligand, inducing keratinocyte apoptosis. You can see here basically the fast receptor on the surface of a TNF alpha stimulated keratinocyte being bound by fast ligand, which activates the caspase mediated forms of keratinocyte apoptosis. Now, the adaptive response for a lichenoid infiltrate is actually hypertrophy. with premature terminal differentiation. And so with increased keratinocyte destruction results in migration of keratinocytes from the lesion edge. It's not due to increased mitotic activity of keratinocytes, but migration from the lateral edges as well as coming up from the eccrine ducts and the hair follicles. There's also alteration to structures of the basal membrane, such as the distribution of type 7 collagen, alpha 6, beta 4 integrin. And what happens also too in the epidermis of lichen planus is that involucrin, which is normally present or restricted to the granular cell layer, is actually found within lower spinous keratinocytes. And there's increased keratin expression of keratin 6, 16, and 17, which are associated with wound healing. And due to this increased keratin content, you're going to have an increase in intercellular adhesion molecules, which is going to result in reduced intercellular spaces accompanied by a reduced cellular turnover. And as a result of this, the dyskeratotic keratinocytes are not going to be eliminated transepidermally, and instead will drop down into the dermis as colloid bodies. And the end result of an interface pattern is typically an atrophic picture versus a hyperplastic picture like you see with a spongiotic pattern. Erythema multiforme is the prototype for cytotoxic interface dermatitis. It's a self-limited but potentially recurrent cytotoxic T-cell mediated response, typically against either infections or rarely drug-related antigens. It's a cell-poor lymphocytic infiltrate with numerous dyskeratotic keratinocytes surrounded by lymphocytes. And again, this cytolytosis implies it's immunologically mediated forms of keratinocyte cell death. The pathogenesis, several studies have failed to clearly identify a specific effector lymphocyte population, but what's known is that 75% of cases of EM are associated with HSV DNA. And what has been shown is that basically these infiltrates are composed of CD4, CD8, as well as natural killer cells, have all been reported, and they all secrete interferon gamma, which is thought to be the important cytokine involved in keratinocyte damage with HSV-associated EM. TNF alpha is not expressed in HSV-associated lesions. Now, in contrast to HSV-associated, drug-associated EM, on the other hand, is associated with CD8 positive T cells mediated keratinocyte destruction via tumor necrosis factor alpha, perforin, and granzyme B, so a different mechanism of disease. Stevens-Johnson syndrome and toxic epidermal necrolysis. This is a medical emergency with progressive deregulated injury of epithelial cells attributed to medications. Histopathologically, it's identical to EM. You really can't distinguish between the two. The difference between EM is a localized, self-limited process, where SJS and TEN is a runaway process involving the entire skin and becoming more severe. But in terms of the pathogenesis, it's very different than EM. It's uncertain, but what's thought to happen is that there's abnormal drug metabolism resulting in drug metabolites that may be expressed on MHC class I molecules. There are elevated levels of Th1 cytokines, and drug-specific cytotoxic T lymphocytes appear to be the main triggering agents as the massive epidermal damage through three mechanisms: FAS and FAS ligand, perforin, granzyme B, and granulysin. And there's some genetics involved here too, with increased incidence in HLA-B12 individuals. Allopurinol is associated with certain HLA types, as well as populations within Japan and China who have been found to have increased FAS receptor on the keratinocytes due to these SNP gene polymorphisms. What's interesting is that basically drug-induced EM actually has a immunological pathogenesis much more similar with SJS and TEN than it does with HSV or virally associated erythema multiforme. Acute graft versus host disease. It's a complication that can occur after a stem cell or bone marrow transplantation, typically within 100 days of transplantation. And again, microscopically, it's going to be identical to EM, SJS, and TEN. It's a cytotoxic, cell-poor interface dermatitis with tagging of keratinocytes along the basal layer with keratinocyte apoptosis and cytolytosis. There's been a grading system that's been proposed, grade 2, which is lymphocyte cytolytosis around dyskeratotic keratinocytes. Grade 3, in which there's some clefting involved, and then grade 4 with actual full blister formation and full thickness epidermal necrosis. The pathogenesis is complex, but what is known is that donor cytotoxic T lymphocytes react against recipient minor histocompatibility antigens. The inflammatory infiltrate typically targets young reedy ridge keratinocytes as well as Langerhans cells. And several effector cell populations appear to be involved, including CD8 positive cytotoxic T lymphocytes, natural killer cells, and soluble factors such as interferon gamma, TNF alpha, fast ligand, and trail. Type 1 interferons appear to not be involved, despite the fact that recent work has shown that HHV6 reactivation may play an important role in the pathogenesis of acute GVHD. Now, the epidermal adaptive response to cytotoxic interface dermatitis is nothing, okay? And that's actually why such a minimal inflammatory infiltrate can cause such massive destruction of the epidermis. So there's no response. Typically, you'll see numerous scattered dyskeratotic keratinocytes with a preserved basket weave stratum corneum over the surface. Vacuolar interface dermatitis, the prototype is lupus. And there are 3 major clinical variants that are recognized with lupus. Acute lupus, which is associated with multi-system disease. Subacute lupus, which is a distinct cutaneous lesions and sometimes associated with mild systemic involvement. Chronic discoid lupus, which is skin limited, and then other more rare variants such as tumid lupus, lupus profundus, and Chilblain's lupus. And histopathologically, what you're going to see is a sparse cell pore interface dermatitis, but unlike erythema multiforme or the cytotoxic pattern, you are going to see some hypertrophic premature terminal differentiation, okay? So some hypergranulosis, thick, compact orthokeratosis. So cell pore, superficial perivascular lymphocytic infiltrate with sparse interface, increased dermal mucin, and eosinophils are going to be absent. On direct immunofluorescence, you're going to see a granular deposition of immunoglobulin as well as complement components along the dermal-epidermal junction, which basically indicates anti-nuclear antibodies being bound. And so basically, you will have a positive lupus band test. That's what defines a positive lupus band test, this granular deposition of immunoglobulin. And it'll be seen in lesional and non-lesional skin in acute lupus or systemic lupus. Now, subacute lupus is typically just a more robust interface process. The infiltrate may extend deep. You're going to have dermal mucin as well. In terms of DIF finding, which is interesting, is you have a positive lupus band test confined to lesional skin only, but an additional feature is you might have nuclear staining, which indicates antibodies for Rho and LAW, which are basically proteins bound to RNA. So you'll actually have some keratinocyte, nuclear, or cytoplasmic staining in subacute lupus. Chronic discoid lupus is a very robust superficial and deep, perivascular and periadnexal inflammatory infiltrate with interface dermatitis. Typically, you'll have follicular plugging as well. DIF, you'll have a positive lupus band test and lesional skin only. And this is basically immunostaining here for MXA, which, remember, MXA is a marker for type 1 interferons. What's interesting is that in terms of pathogenesis, there's a slight predominance of CD4 cells over CD8, but it's thought to involve multiple genetic associations that include sequence polymorphisms of genes that regulate the expression of HLA, TNF alpha, as well as complement components. Type 1 interferons are actually strongly associated with cutaneous lupus, as well as autoreactive cytotoxic lymphocytes, which target epidermal keratinocytes and adnexal structures, which eventually result in scar formation in the chronic discoid lesions. There's also a strong expression of granzyme B, as well as circulating anti-nuclear antibodies, which will deposit on the basement membrane where extracellular DNA is going to be concentrated. So what event kind of unites the innate and autoimmune components in cutaneous lupus? And it's interesting, so recent work has actually shown that TREX1 is an exonuclease that cleaves single-stranded and mismatched DNA. And missense mutations in TREX1 results in accumulated large fragments of DNA, and these large fragments actually are mistaken by toll-like receptors and our own innate immune response as being viral DNA. So what happens is binding these large fragments of DNA will activate toll-like receptors and then the large secretion of large concentrations of type 1 interferons, namely interferon alpha. Excessive INF alpha may further lead to upregulation of toll-like receptors in autoreactive B cells and the formation of anti-nuclear antibodies, thus propagating an autoimmune response. Immune complexes will then increase TNF alpha signaling in myeloid cells, which will further enhance apoptosis and inflammation, bringing in more large fragment DNA, thus creating a positive feedback loop. And what's been shown is that there are rare polymorphisms in the TREX1 gene that have been linked with the increased risk of developed sporadic systemic lupus. So in summary, conditions with similar clinical and histopathologic findings may have disparate immunological mechanisms of action. Complex combinations of innate and adaptive immunity are involved in cutaneous inflammatory disease, and understanding the complex immunological basis of disease is essential in establishing effective targeted therapies. As a general take-home message from this talk, as the general trends go, extracellular antigen-associated diseases manifest a spongiotic reaction pattern, whereas intracellular antigen-associated diseases manifest an interphase reaction pattern. The adaptive epithelial response provides further insight into the mechanisms of disease, and developing additional markers that can coincide with immunological pathways will further enhance the diagnosis and treatment of these conditions.